I am Paola Calleja, urologist at the University Hospital Marqués de Valdecilla, and I'm going to present the indications and outcomes of vaginal closure of VVF in a first world setting. Iatrogenic Vesico-Vaginal Fistula are closed vaginally in approximately 70% of the cases. The reason for abdominal closure is often limited vaginal access rather than absolute indications, such as synchronous ureteric involvement. We postulated that surgical preference often dictates the choice of abdominal route. We have compared the routes and outcomes of 3 consultant surgeons working closely together at different stages of their careers and with different levels of experience in VVF repair. 137 women having surgery for VVF between January 2002 and March 2019 were retrospectively identified. Data on patient demographics, fistula etiology, position and size, surgical approach and outcomes were collected. The surgery was performed by one of 3 consultant surgeons dedicated to reconstructive surgery. Whenever possible, an interposition graft was used, either a Marshall's fat pad, omentum or peritoneum. We consider absolute indications for abdominal repair, the need of simultaneous ureteric reimplantation, and the closure of associated fistula of the bowel. The patients were reviewed for surgeon, surgical procedure, route of VVF closure, percentage of anatomical closure after first attempt, and overall closure. The median age of the cohort was 50 years. There were no significant differences in patient or fistula demographics. Median fistula size was 1.25 centimeters, in a range from 2 millimeters to 7 centimeters. There was synchronous ureteric involvement in 7 patients and concomitant colovaginal fistula in 4 patients. Regarding medical background, 10.6% of the patients received pelvic radiotherapy, being the main cause of the fistula in 35% of them. 12% have undergone a previous closure attempt before referral. The most frequent cause of the fistula was hysterectomy. Only 21% of the cases was secondary to a malignant cause. Fistula repair was discarded in a total of 8 patients, mostly because of extensive radiotherapy damage. The route of repair seems to be highly influenced by the surgeon preference. There is a statistically significant difference in vaginal repair rates between the surgeons, which cannot be explained by absolute indications of abdominal repair. However, we also observed that experience influences this decision, trying to exhaust the vaginal approach, which has little morbidity, and only use an abdominal technique when there is an absolute indication for it. If we look into true vaginal repair, assuming only absolute indications will result in abdominal repair, we can notice how the use of vaginal repair is a matter of experience, but also personal preference. Primary closure rates vary from 78 to 93%. The overall closure rate is excellent, higher than 85%. However, it must be taken into account that all 3 surgeons are dedicated to reconstructive surgery. In summary, VVF closure rates are excellent in experienced hands, over 85%. The route of repair seems to be a combination of surgeon preference and experience. Thank you for your time.